So thank you all for your courage and perseverance to make it through to the very last few minutes of this excellent conference. So my goal is to provide some background about Clostridium difficile so you have a better understanding of some of the reasons our patients are in so much trouble when it comes to C. diff. That'll, I think, actually help you identify the patients who are going to be particularly susceptible. We're going to talk a little bit about diagnostic considerations. We're going to talk about initial treatment options, and then one of our bigger challenges definitely is going to be treatment of recurrent disease. So Clostridium difficile literally means the difficult Clostridium, and this had to do with the fact that C. diff is part of the normal flora of neonatal infants. It was difficult to culture this organism, and nowadays we have no problems culturing it, but unfortunately that's in our hospital wards and taking care of our patients. It's a gram-positive spore-forming rod that you see here in this colorized image. C. diff was, again, part of our normal flora until antibiotics showed up. And antibiotics will actually have an impact on our microbiome. Obviously, it's going to lead to a disruption of our normal flora. And the association with pathology emerges in the 1970s with pseudomembranous colitis. ELISA testing, the ability to actually make a diagnosis of C. diff, shows up in 1984. And we're all well too familiar with this clinical syndrome, which can range from very mild disease, and endoscopically it could look like a normal colonoscopy, to what we're seeing here, which is the classic pseudomembrane. Pseudomembranes are only seen in about half of the endoscopic assessment of C. diff. It's a marker of severity. When you see a pseudomembrane, please keep in mind that that person has now moved into a higher level of severity. And when we think about our IBD patients, don't wait for pseudomembranes. Pseudomembranes are actually fairly rare in the IBD patient cohort. So again, over the past several decades, there has been a dramatic rise in C. diff infections across North America. We used to have some success back in the perhaps 1980s and early 1990s with the use of metronidazole, but there are now published papers suggesting that the metronidazole failure rates are much higher than expected, approaching 50% failure rates. This is work coming out of Houston from Daniel Musher's group. In addition to these challenges with more patients and refractory infections, there is a strain of C. difficile, the epidemic strain, the BINAP1 epidemic strain, which has a gene deletion in the TCD-C gene, which regulates the production of toxin B. So there's a 20-fold increase of toxin production, which results in a much more dangerous infection. And in the early 2000s, there was a series of articles that emerged. Hospitals, Sherbrooke, Quebec, Canada was particularly hard hit. Pittsburgh was hard hit, where there was actually spore contamination of the hospital, and literally wards in the hospital had to be shut down because of the level of severity of infection that was going on. And the current burden of C. difficile in the US is staggering. We have over 450,000 infections per year. That corresponds with 29,000 deaths. This is the whole population. This is not just IBD. And the estimated cost is going to be $5.9 billion in excess expenditures. Again, one of the major scientific discoveries over the past several years is our new appreciation of the microbiome and how this vast ecology of organisms living inside our GI tract is going to impact our health and potentially disease states. So approximately 2 kilograms of bacteria, fungi, archaea that live in our GI tract. We're only 10% human. Only about 10% of the live cells in our body are human cells. Literally 90% of the live organisms in our body are coming from the microbiome. And if we think about the C. difficile being a commensal organism in a state of nature without antibiotic therapy, we are left with the question, what mechanisms will allow someone to not become infected, and what mechanisms will potentially contribute to the emergence of this terrible infection, C. difficile? And this schematic, I think, provides some very important take-home messages. Again, antibiotics will have an inadvertent effect on the microbiome in the GI tract, where we have a disturbed, injured microflora. Individuals who have a disturbed microflora lose colonization resistance that would otherwise keep C. diff under control. But importantly, a person has to make an immune response to C. diff toxins in order to become an asymptomatic carrier. You literally have to make an immunoglobulin G immune response to C. diff toxins in order to become the asymptomatic carrier, which is the majority of the individuals who will actually have this carriage. And I would comment that approximately 1/3 of hospitalized patients in an acute care hospital will actually screen positive for C. difficile. Where I work at UPMC Presbyterian Hospital, we have approximately 27,000 admissions per year. We have 1/3 of our patients screening positive based on PCR analysis on a VRE screen, but only 500 of our patients will actually come down with an infection. So when we actually approach the C. diff infection, we will first turn to antibiotics. This is the standard. We have to do this, but that will potentially lead to further dysbiosis. And approximately 1 in 4 patients in the general population treated with antibiotics will have recurrence of C. diff infection within a 2-month to 3-month time period. So we are building in our own mechanism of failure when we unfortunately have to go through this. Getting back to that point about immunoglobulin production against C. diff toxins, this is work that comes out of Kieran Kelly's laboratory at the Beth Israel Deaconess Medical Center in Boston, where they really clearly defined that the ability to make antibodies against toxin was essential in clearing infection and preventing recurrent disease and becoming that asymptomatic carrier. If we shift gears and start thinking about the pathogenesis of IBD, this is our classic Venn diagram where there's genetic predisposition overlapping with environmental factors, people living in westernized societies, people who are predisposed to certain types of immune dysregulation, but we need to update this Venn diagram now with the microbiome. And there is, again, growing evidence that there is a dysbiotic flora in our patients with inflammatory bowel disease. We have a heat map on the left of a healthy person who has a robust flora, and the vast ecology is now being classified based on the phyla. And we can contrast this with the heat map, which shows a dysbiotic flora in an IBD patient. And the worse the dysbiosis in the flora, the higher the rates of flare, the higher rates of problems, and also we can also extrapolate the higher rates of C. difficile infection. So we've come to realize that there are certain populations that are at exceptionally high risk of getting into trouble with C. difficile infection. We have on the top of the list ulcerative colitis, where close to 4% of the population could have a C. diff infection each year. Crohn's disease, particularly Crohn's colitis, are going to be at increased risk. But the rest of the conditions that I have listed here, solid organ transplants, lung transplants in particular, exceptionally high risk of C. difficile infection, liver transplants, allogeneic bone marrow transplant patients. And the common denominator is that we have impaired humoral immunity. We've really broken the ability to produce antibodies with all of these medical interventions and the drugs that we will turn to on a routine basis. And the antibiotic exposure that's going to be a part of the organ transplant population really creates this dysbiosis that sets up this cycle of C. diff infections. So if we start thinking specifically about IBD and C. difficile, an IBD colitis flare mimics a C. diff infection. We talked about this yesterday in our case discussions. There's really no way to distinguish between a C. diff infection and a colitis flare unless you go through that exercise of doing the stool testing, trying to make the diagnosis, getting that history about risk factors. Was this person exposed to individuals who have C. diff? Is their occupation going to put them at risk being a healthcare provider? And there's been a real sea change in our understanding of this relationship. Literally 3 decades ago, there were published papers suggesting that when C. diff testing became available in the 1980s, we didn't have to have suspicion in the IBD patients. The early studies did not show an overlap, but more recent data has shown a tremendous impact of C. diff on our patients. And I have some endoscopic images here of patients who have had confirmed infections. Again, it's not a classic pseudomembrane. What I'm looking for is what I would describe as mucopus on the colonic surface. There were 2 institutions that had back-to-back papers in clinical gastrohepatology a decade ago. The group at Wisconsin, where I was at the time, and colleagues at the Washington University in St. Louis, where we saw this dramatic rise in C. diff occurring over the years in the early 2000s. And this corresponded to marked rates of hospitalization and marked rates of colectomy. Now, we followed up these 2 single-center studies with this work that was done by Ashwin and Krishnan on our podium, our chairman, who actually looked at the nationwide inpatient sample data set from 2004. That's 1,000 hospitals that share data in the United States, acute care hospitals. And what they found, what Ashwin found in this paper, was the mortality associated with an IBD admission was fairly modest. C. difficile infection, again, it's an elderly cohort traditionally, so they have other comorbidities, but IBD patients who had a co-infection with C. difficile literally had a 4% mortality. And if we actually look at the data from this paper, there were 118 patients who literally died due to C. difficile at that time. And if we extrapolate up to the total number of acute care hospitals in the United States, we can estimate over 500 IBD patients were dying at that time period. Now, the increase in C. diff continued beyond the 2004 time period up into 2007. So this is not a problem that's going to be going away. But I think the progress that we've made comes from the fact that we are all now hyper aware of this. You're not going to be surprised by C. difficile. You should be testing for it. You should be looking for it. When I hear excellent presentations like Dr. Chaffetz's presentation on drug monitoring and therapeutic drug monitoring in an IBD patient population, the confounder is this infection. You can't interpret therapeutic drug monitoring properly if C. diff is in the picture. It's going to give you a mixed message. It's a confounder. So it's essential that we look for this issue to optimize care for our patients. And lastly, when patients with ulcerative colitis were going to the operating room, there was a mortality of 25%, again implying that there had been a horrific acceleration of their disease trajectories. Now this is, unfortunately, I'm going to share with you some data that we generated a few years ago. Scott Curry, an infectious disease colleague, and I, we were trying to figure out where is this coming from? Why are our IBD patients so incredibly susceptible to C. diff? Where is this coming from? And we all, I think, are well acquainted with the fact that C. difficile is a spore-forming organism, and the C. diff spore can exist in the environment for up to 60 days. What we have here on the right is the longevity of spores that are actually on a metal disc exposed to air, and these are lasting literally for months. The second diagram on the right is actually C. diff spores that are being preserved in ethanol. The longevity is actually better when you actually put the C. diff spores in ethanol that would kill vegetative bacteria, but the spores will survive. And then the last image on the right is the ability to kill C. diff spores, and you literally have to have Clorox making contact time for 10 minutes to get significant killing. So the majority of our IBD patients are contracting C. difficile as outpatients. IBD patients have frequent contact with the healthcare environment, typically through our clinics and our offices. So we asked the question, does the clinic or physician office pose a risk for C. difficile infection? So we actually did an epidemiologic survey where we swabbed our clinic exam rooms and literally grew C. difficile from half of our exam rooms. And when we followed this up on what was the fomite, what was the issue in the clinic, it was the patient chair. So I don't think we're actually Cloroxing down our patient chairs when we're seeing a template of 20 patients in a daytime. And the other device that was contaminated with C. diff spores was the keyboard that we're typing on in our clinics. So we have to be aware that when a patient has had C. diff, we might want to do a terminal clean sometimes in our clinics. This study led to us replacing all of our keyboards with dishwasher-safe keyboards in our outpatient clinics. Here's work from Ashwin and Krishnan that actually looked at modifiable nutritional factors that can contribute to the development of a C. difficile infection. And it turns out that vitamin D, a very simple parameter that we can check for routinely and supplement, has pretty profound importance in terms of normal immune function and the ability to perhaps control chronic inflammation. And when vitamin D levels were less than 20, there was an odds ratio over 2 in terms of increased risk of C. diff. So this is something that has not yet been prospectively targeted, but it's actually ripe for investigation. This is a paper that our group in Pittsburgh just had come online recently, where we actually looked at the cohort of patients with IBD who contracted C. diff and a matched cohort of IBD patients. We had about 200 patients in the study, 1/3 of whom had C. diff. And we matched the patients the year prior to their C. difficile infection. And we were actually intrigued by the finding that the IBD patients who get C. diff are sicker than average. These patients had worse quality of life in general. They had elevated C-reactive protein rates, much more so than the regular population. There was more antibiotic exposure as might be expected. There was more vitamin D deficiency. These were many patients who'd come through healthcare procedures. And when we looked at their healthcare charges, which we curate as part of our IBD registry at the University of Pittsburgh, and looked at the charges the year after that C. difficile infection, we found that there was a 6-fold increased rate of charges. And this really implies that when the IBD patient gets C. diff, it will potentially change the trajectory of their illness going forward. So these are sicker patients in general, and they're going to be sicker after having been through this exposure. Again, work from Ashwin and his colleagues at the Mass General suggests that some of the strategies for personalized medicine and precision medicine in IBD care can actually identify ulcerative colitis patients who are at risk. So I know Corey Siegel's model that he talked about using a NOD2 genome polymorphism, there's actually a suggestion that multiple genetic risk alleles stacked together are going to be increasing the risk of a person with ulcerative colitis to get this infection. When we think about diagnostic considerations, stool studies are essential. We have no other way to make the diagnosis, but really clinical suspicion is the key issue. We have to send off the test. We have to make the diagnosis. Now, the American College of Gastroenterology came out with a guideline paper in 2013, and the real, I think, important message was to identify high-risk populations, do the testing, don't be surprised by this. Now, we heard from Dr. Katz that the elderly clearly is the prototypical risk factor for getting into trouble with C. diff, but it's not the only group of individuals. These young folks here with IBD have a double hit due to a dysbiotic flora and lots of immunosuppression and unfortunately still too much steroid exposure. So 5 out of the 7 categories that were identified for the ACG guidelines emphasized identifying IBD patients, J-pouch patients, people who've been stable with their IBD, suddenly flaring. These are all the scenarios where we have to make that diagnosis. And every IBD patient admitted to the hospital, it's mandatory that we send off testing. What we have here is the J-pouch patient population. So this is an individual on the left who had a diverting loop ileostomy, and in between that 2nd and 3rd stage procedure, they ended up becoming very sick, very severe fevers, abdominal pain, and what we're seeing here on the sagittal reformat is a dilated downstream bowel that is fluid-filled. And this is really the classic appearance of a C. diff enteritis, and endoscopically, this person had this mucopus that we're seeing on their J-pouch that extended up to the diverting loop ileostomy. In general, C. diff enteritis, C. diff infection of the small intestine had incredibly high rates of mortality because we weren't looking for the infection. This was a post-mortem diagnosis historically. We need to be aware that C. diff is not only a disease in the colon, it can be a disease of the neocolon in the J-pouch, and can also be a C. diff. There can also be a C. diff infection of the small intestine in patients with an endoleostomy. So we've had a number of strategies. PCR has emerged as our major modality, and I wanted to highlight that the sensitivity of PCR analysis is pretty variable. It's not close to 100% in all of the assays that are out there, and I don't think we have gold standard data yet to tell us what the exact accuracy of this testing is in the IBD patient population. So clinical suspicion is essential. If you think you need to treat someone based on suspicion, go ahead and treat. PCR testing is not a reason to withhold therapy. And one last thing I would comment on diagnosis is that the PCR testing will turn negative in people on therapy relatively quickly. By day 5, the majority of patients on antibiotic therapy will turn negative because you've killed off vegetative organisms, but spores are still colonizing the GI tract. So for treatment options, to cut to the chase, vancomycin is our preferred strategy. Metronidazole is an inferior drug, particularly in the hospitalized patient population. The ACG guidelines emphasize treating based on severity of illness, and the drugs that are appropriate for more severe illness in people who are at higher risk is basically vancomycin and fidaxomicin. The reason vancomycin is superior is this study that was done a number of years ago outside of Chicago, which proved that in a severe cohort, metronidazole is not as effective. And there is increased mortality in the IBD patient population that's hospitalized with metronidazole use. This was a follow-up study that we undertook in Wisconsin a number of years ago, where we emphasized the high index of suspicion, identifying C. difficile in our hospitalized patients, not using metronidazole as an antibiotic in this population and switching to vancomycin. And what we saw was a really dramatic decrease in the colectomy rate amongst the hospitalized patients. Even though we had identical rates of hospitalization, we made an impact in preventing patients from going on to colectomy. Now, the antibiotic that I mentioned a minute ago, fidaxomicin, has been FDA approved for a number of years. And unfortunately, this drug, which is a very effective drug for severe C. difficile, did not include IBD patients in the pivotal trial, in part because a clinical result, the ability to resolve diarrhea, was part of the study design. And the IBD patient population is a much tougher population. We can't use that simple a protocol. We're going to touch on recurrent disease. So 1/4 of our patients treated successfully for an initial C. diff infection will have a recurrent infection. 1/3 of the IBD patient population, higher than the general population, will have a recurrent infection in this short-term time period. And the success with additional antibiotic therapy will decline. And unfortunately, we're going to have very, very limited data to describe this. So recurrent C. difficile infections have essentially doubled in the past decade. This is perhaps our best data when it comes to recurrent C. difficile infection. It's coming from our colleagues at the University of Toronto, who looked at their experience over a 3-year time period with 500 patients with C. diff, 20% of whom had IBD. And they found that their general population, about 1/4, as was expected, would get recurrent C. diff, and it was 32% of their IBD patient population with much worse outcomes, much higher rates of colectomy. It was approximately a 20-fold higher risk of colectomy. Now, this is data that's emerging from the Mayo Clinic that suggests that if we extend our antibiotic treatment with vancomycin into long courses of therapy with tapers beyond essentially 6 weeks, we can have decreased risk of recurrence. Not an IBD study, but the suggestion that we need to actually treat longer. And many of us who are doing this on a regular basis will actually go for getting close to a 2-month therapy to try to prevent recurrent infections in our patients who've struggled. Fidaxomicin has clear efficacy in this population. It actually does better in terms of preventing recurrent infection because of a little bit more narrow spectrum of activity. And the last slide for therapy I have here is an FDA-approved drug from last year. It's the drug bezlotuximab. Bezlotuximab is the ability to provide a passive immune vaccine to our patients. So individuals who are responding to C. diff therapy can receive a 10 milligram per kilogram infusion of this IgG1 antibody that really targets the C. diff toxin B, and it will lower recurrence rates. There were literally 2,400 patients in this trial, 24 of whom had IBD. So not enough for a signal, but we're looking forward to hopefully some data emerging in the not too distant future. For fecal transplant, it works for the IBD patient population, not quite as effective for the general population. We heard yesterday from Ed Loftus, there is a problem in some of our IBD patients who have an immune reaction to fecal flora, but this is a modality that can definitely be used in the recurrent population. So I'm going to wrap things up with take-home messages. Please have a high index of suspicion for C. difficile infection in the setting of an IBD flare in individuals who have had a refractory disease. Keep in mind that C. diff enteritis and J-pouch infections definitely can occur. Nucleic acid testing with PCR is an advance, but it should not be a reason to withhold therapy. So if you have a high index of suspicion, go ahead and start treating. At present, vancomycin is our preferred strategy, but prolonged courses beyond 2 weeks are sometimes needed, and we have to do that in certain situations. C. diff infection recurrence in the IBD patient population is higher than in the general population, and it may occur in approximately 1/3 of our patients. Fecal transplant is available and can definitely be used in this population with recurrent disease. IBD patients who contract C. diff are sicker in general and have higher rates of steroid and antibiotic exposure. And then lastly, steroid exposure in and of itself, as we've heard throughout this meeting, is a problem. It's definitely a risk for C. diff infection, and minimizing steroids, particularly in hospitalized patients with a preference for biologic therapy, is often needed. Thank you very much.